Welcome to Life in a Body You Love Chicks. I have an amazing special guest here for you guys today. This is my gal, Dr. Sarah, and we're going to talk all about hormones today. So buckle up, sisters. You might actually want a pen and paper for this one. There's a ton of information circling the interwebs right now. This is a super hot topic, and she is a doctor, but she's not your doctor. I am a nurse, but I'm
Mhm.
not your nurse. In fact, I'm not anybody's nurse because I quit nursing. So none of this is medical advice. Okay? Talk to your own doctor. But we want you guys armed with like good information for having those conversations with your doctor, knowing what your options are, what's fact, what's fiction. We're not doing medicine off TikTok videos and shit like that. So, Dr. Sarah, thank you so much for being here. Do you want to tell everybody a little bit about yourself and like how
Yeah.
you got into this line of work?
Yeah, I would love to. Well, first off, thank you for having me. And a little bit of background that I think is kind of important is that all before Nikki quit nursing, which I'm very happy she did for herself. But when I was a resident, actually, is when I met her. So we've been in we've been in the foxholes together, let's say that. But I'm Dr. Sarah. I am board certified in emergency medicine and integrative medicine, and I love all things longevity, women's health. And the reason is that the system is broken, whether you're in it, you're not, whatever you believe it is. It's meant to treat disease and illness, and that's how it is. That's how we were taught. That's how I learned in medical school. It wasn't until my all my other training that I do. That I learned other different ways. But my mission and my passion really in life is to educate women the best we can. Because guess what, ladies? We are smart, we are competent, and we can make hard decisions. We do it all the time unbeknownst to the world around us, right? They think that we can't, right? And they can tell us no. And that's really my mission in life is Nikki's right. I am a doctor. I'm not your doctor. If I am, and you happen to be watching this, awesome. But we're not giving you personal medical advice. What we're doing is we really want to arm you with education, with knowledge, right? That you can go out there and you can make the movement. The zeitgeist is talking, right? Women's health is coming up, and that is amazing. For the first time in so many years, we are actually talking about things. But that also is a little scary. And the reason is you do have these TikTokers, these influencers who are telling you things and saying stuff that they probably have no business telling you or saying. And so, although I'm happy that we're talking about it, it is important where you get your information from. Okay. So, I do want to tell you that it is important where you get information from. And the other thing I want to say is that if you are meeting resistance from a provider, your physician, whatever, get a new one. It really is that simple. Okay. And we're going to arm you. My goal today, I think it's yours, is to arm you with education, information, and some empowerment, right? That you feel confident at the end of the day. Maybe you need to do a little bit more research, but you feel confident at the end of the day that you're going to go in and you're going to advocate for yourself because you know what you know. Okay. And so that's what I'm trying to get across today, if you're okay with that, Nikki.
That's 100% why I wanted you here, Dr. Sarah. So, first of all, obviously, there is this huge fear around hormone replacement therapy in menopausal women. You know that we both have feelings about this, but how did we get here? Let's start there. Why are we so afraid to
Yeah.
replace hormones for women
Great
in
question.
menopause?
Great question. And really it goes down to, back in the 1980s, 40% of women were on hormone therapy, right? 40% of women were living life, they're on hormone therapy. And then in 2002, the WHI came out. Now, the WHI really did start with a really great intentions, right? It was a very, very well-funded study. A lot of doctors came together and said, look, we think women are doing really well on hormone therapy. Let's put some data behind it, right? And it was the most funded women's study that we've had to date, and probably, to be honest with you, will ever have. But there was a lot of problems and a lot of ridiculousness that happened with the WHI. And in 2002, they stopped the study short and said, oh my gosh, there's an increased incidence of breast cancer in women taking HRT. Okay. And literally, this set women's health back 60 years in a one day. And now, granted, I was not around for this, right? Like I was just graduating. I wasn't even graduating high school yet. So I wasn't even around for it. But what happened is in one day we have all these women taking hormone therapy, and then the next day they all stop. Okay, it's mad chaos. I can't even imagine what it's going to be like, what it was like, right, for these doctors. Well, here's the thing: all the doctors that have been prescribing these medications, these hormones for women for 20 years, they went to the principal investigators and were like, "What are you talking about? We do not have clinics full of women with breast cancer and DVTs and strokes and heart attacks. Like, I don't know what you're talking about, but that is not what we're seeing. Like, this is crazy." Okay. So, without getting too crazed into the women's health study, and on a different day, we can do that. We can go into the nitty gritty. I'll tell you a little high level. The women's health study initiative looked at two forms of women, right? Women that had uteruses, and so they gave them conjugated equine estrogen and a progestin, which is synthetic. Conjugated equine estrogen is from the urine of pregnant horses, okay? And then they gave the women without uteruses just estrogen alone, okay? And then they studied them. Now, here's really where the crux of the problem comes is that the women that they studied, the mean age of the women were in their 60s. Now, that's a problem, ladies, because we have menopause in our 50s, right? And perimenopause can be in our 30s and 40s. So that is not even the correct age of women to be looking at who take hormone therapy, right? Or starting on hormone therapy. So there was a lot of things that went wrong. But at the end of the day, they came out and said, this increases the risk of breast cancer. I think it was like by 24%. And that's actually wrong. That's all been walked back now. And we just had a humongous win with the FDA with taking the black box label off estrogen products. This is huge. Huge, huge, huge. Because even though I've prescribed estrogen to hundreds and hundreds of women, when you get home, no matter how great I educate you, when you get home and you get your vaginal estrogen, it's even on vaginal estrogen. I mean, come on, okay? You pull this out and it's like can cause cancer, strokes, heart attack, all the stuff that's fake, not true, right? You're not going to take that, right? Some people like threw
Right.
the freaking estrogen away and they're like, I'm like, remember what I told you. It's fear mongering, right? And it harmed women. So that's how we got here. And then not only that, but then there was 2 decades of physicians that were not trained in hormone therapy. And that's really where the problem is too. And even now that this has happened, now we're in the zeitgeist, we're talking about it. We still have a lack of physician training problem. Okay. And so it does make me a little nervous that we haven't caught up yet because now women are demanding it. And that's why it's very, very, very important that you find a provider or physician that knows what the heck they're doing. And I can say hell on here, I think. Hell, they're
Yes,
doing.
you can say whatever you
Okay.
want here.
Knows what the hell they're doing because this is very precision guided. Women's health, women's longevity, women's health span, right? Health span, lifespan. Health span is how many years you live well, right? I don't know about you, but I'm not interested in being 90 if I'm demented in a nursing home with a broken hip and a UTI peeing in my diaper. Okay. Kill me at 80, right? But what we're trying to do is increase women's health span, the years that you live longer, healthier, innate longevity, right? That's what longevity is, right?
Yes.
So that's kind of how we got here. Now we got to navigate these waters carefully in the next little upcoming years until we can get the physician population back up to speed. What I will say from a physician perspective is this has been my world for years, so I'm immersed in it. But I have seen in a lot of my physician groups a very big turn in, especially from the women physicians, and like, hey, what course can I take? How can I learn how to prescribe? Like, so I'm very happy we're going to do it, right? But the biggest important part is you, right? Educating you is so important for many reasons. One, so you know what to do and ask for, and two, so that we can create a culture for our children, for our daughters where this does not exist. We talk it, we speak it, they understand what's going to happen, and it's preventative, right? We're like, okay, you're 35, get your vaginal estrogen. We want it to be medicine 3.0. We want it to be part of what happens, right? When I see women at 35, okay, my 25 years, okay, go get a DEXA scan. I want to see what your bone health looks like before you're ever estrogen deficient. See what we're dealing with, right? And then, okay, now you're 35. All right, here's some vaginal estrogen. Here's this, let's talk about this, right? We want it to be preventative And we have a while to go for that. But that's how we got here, and that's the state of the world today.
Yes. Okay. Thank you so much. I think it's important that people understand that study didn't follow through appropriately on the scientific process either. And we won't get into all the details, but
Mhm.
the whole entire process kind of fell apart. And so we have data now that tell us no, it's not for the average woman who starts on HRT at the appropriate age, not waiting 20 years post-menopause.
Sure.
And which, I mean, some people are even doing that now, but regardless, you start at the appropriate time, you start with the appropriate doses, and you don't have specific risk factors. It's not dangerous, correct?
Yeah.
Is
Yeah.
that what you're
And
saying?
exactly. So for the majority of women, it is not dangerous. There is certain women that we have to talk about, right? It's very personalized. Again, this is not blanket. This is medicine 3.0, people. You shouldn't even take the same supplement as your friend unless you know what you're doing, right? And
Yeah.
there's no one size fits all with anything in medicine, and that's a problem with medicine, part of it. We say, "Oh, you have hypertension, take this. You have this, do this." Now, this should be really precision guided. So but to talk in generalities, yes, the average woman who has no comorbidities, it is safe to take estrogen and
Right.
hormone replacement, whatever you need, estrogen, progesterone, testosterone, depending on all the things. Yes.
And to Dr. Sarah's point that like you need to find a physician that you can have these conversations with. So there's two ends of this. One is you go into your doctor's office and you're like, I've been hearing talk about hormone replacement therapy. I want to have a conversation and see if this would be beneficial to me. And some bro doctor who graduated med school in 1954 is just like, nope, causes cancer and blood clots, can't have it. And they're not even talking about you specifically. They have this blanket statement idea about it that tells you that they're not up to date on the current research. On the other hand, what we're not saying is if you're speaking to a physician who is very educated on this and you have very specific risk factors, those are real. And
Yeah.
you don't want to just go pop into some random clinic that'll put pellets in anybody's ass either. So
Right.
it's this
100%.
this is
100%.
very nuanced. We're not saying everybody go get on HRT,
Right.
but for the average woman who is going to go through menopause in her 40s or 50s, why might she want to consider it?
Yeah.
What's the benefit to doing so?
And I always tell people, I could care less if you go on HRT or not. And I don't mean that meanly. I really don't. What I care
You're like,
about,
by the way, no estrogen company's paying me to say
no,
this,
and
like,
by the way, there's no money in estrogen, just so you guys know.
which is why it doesn't get
Which is
studied more.
why we're here where we are, right? Because the big pharma can't make money, couldn't make money on it. So that's another story. But I don't care if you go on estrogen or not. What I care about, right? And remember this, you brought up a good point about a bro, but I will tell you, I had a discovery call with a patient yesterday who a young female doctor dismissed her. Okay. And you better bet your bottom dollar I was on the phone with that doctor because she's also a military doctor and I am too. And I called her little ass right up and had a little bitch fest with her about her.
Stop, you
And
did
I know,
not.
yeah, the lady called me. She knows me from the military and was like, I need your help. I watch her YouTube, whatever. And she said, this is what she told me. You don't need, you don't need that. I'm not giving you that, like blah, 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 blah. Right. Like talking at us. Nobody talks at us, ladies. I want to let you know. Nobody gets to tell us no. First off, the conversation is here's what this is. Here's HRT. Okay. This is what it can do for you. This is what your risk factors are. This is what this means. What do you think? Here's the data. I'm going to tell you what your risks are if you do it. I'm going to tell you what your risks are if you don't. What are you comfortable with? Nobody gets to tell us no. That's bullshit. It's bullshit all day, every day. We can make our own damn choices. And even if we have risk factors, we can make our own damn choices. I might be okay taking, a 9% risk at a blood clot if I have a 60% risk of heart disease, right? 1 in 4 women die of heart disease, folks. So, like, let me choose my own damn risk. Your job isn't to tell me no, it's to educate me. And
And
that's
there's
exactly,
risks in acting and in not acting as well.
oh,
And so
yeah.
that's the thing that people don't get. I think sometimes it's like, well, if I just ignore this, I don't have to worry about those risks. And it's like, but sometimes there's a risk in not acting, and you need to
Of course
understand
there
what
is.
they all are. So we're
Yeah.
early menopausers in my family. I'm
Yeah.
43,
Yeah.
and I've ovulated my whole family, Sarah. they all stopped having periods in their late 30s. How
You're
crazy.
well, there's some things to that. Like also could be on depending on their lifestyle, right? So you
Yeah,
live a pretty healthy lifestyle and you have baseline support and things like that, right? So I'm sure you
right.
have better mitochondrial function. And remember, the mitochondria, the ovary is the most mitochondrial dense organ that we have in our whole body.
And
So
that's why I've
there,
had 3 more years of periods than my mother did, and five
yeah.
more than my
Which
Gigi so
which
far.
actually for you is good, right? Because the longer you have estrogen, then we know your risk of heart disease. So here's why, going
So
back to the
we all
question.
have early heart attacks as well, all the women in my
Well,
family.
that's
And
why,
so
right?
for
That makes
me,
sense.
I'm like, I might have an increased risk of breast cancer that doesn't run in my family whatsoever. And actually, I don't have an increased risk, but that's what the fear is, right? And I'm like, but that doesn't even pertain to me specifically. We keel over of heart attacks. So
And we know we can
everybody needs to
use
look at
it.
their own risks.
That's all right. So here's why someone would go on HRT. Here's like the things that back to the question. Sorry, I kind of ranted off
We
there.
both ran
Um,
squirrel.
why somebody would look at it. So what do we know? And actually I was just at the Menopause Society conference in October and we just published a new study was dropped that we had been waiting to come out that shows the earlier that you go on estrogen, the more decreased risk you have of heart disease. 60%. Did you hear what I just said? So let me take this back for you. 1 in 4 women will die of heart disease. 1 in 4. Okay. 60% reduction in heart disease if you
I
start
need this
estrogen
study.
earlier.
I'm so
It's on the
excited
Menopause
to
Society. I can
I'm
send it.
so excited to read this. I'm gonna
I
go
can
get
send
it
it to
as
you,
soon
and
as we're done.
it's also inside my collective. Like I do a newsletter with it, but I'll send you the link. It dropped at the Menopause Society, like 500, women, doctors in the room, like we're celebrating and we're happy because we already knew this, right? But now we have
Right.
some data, so we're happy. But anyways, so why go on? What are the benefits of HRT? Number one, right now in the United States, it's FDA approved for prevention of hot flashes, night sweats, gentle urinary syndrome of menopause, and osteoporosis. Okay. And another study actually just dropped showing that hot flashes are not just benign, annoying things. Hot flashes are cardiovascular and neurologic. And they looked at women having hot flashes and they did MRIs of their brain and they showed white matter changes. Did you hear what I just said? Mini little freaking ischemic strokes. Okay. So the
And
more,
we're all terrified of dementia, and we
yes.
know, yes, 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 yes,
Yeah.
yes. Oh
And
my
then
gosh.
then we know already that there is a correlation between hot flashes, their intensity, and cardiovascular disease. And here's again the little short of it, just a little estrogen education. Estrogen is responsible for 400 processes in the female body. 400, okay? The next hormone secondary to that is the thyroid, and it's about 200 to 250. Hello, if anybody doesn't think that estrogen is important or we need it for the female body. But what it does from a cardiovascular standpoint is that estrogen makes your vessels like this. Ooh, ooh, nice and flowy, okay? So what happens when women start to become estrogen deficient, which happens in perimenopause and estrogen becomes chaotic, those vessels stiffen up. That's why women get palpitations. That's why women get sometimes this, oh my gosh, all of a sudden I have palpitations and this fear and this and sense of doom, right? It's because their heart rate goes up, right? Because everything's stiffening up. And then what happens over time when you have stiff vessels or the old term hardening of the arteries, if you want to take it back to that, then plaques can form, right? But when your vessel walls, the endothelium, right, which is a big thing, endothelial health is huge in cardiovascular health. When all of that is like flowy and nice like this, plaques can't stick to that, right? It's
Right.
like,
And blood pressure is better and all of the
yes,
things.
blood pressure is better, all of that, right? So, from a cardiovascular standpoint, although not FDA approved at this point in the US for prevention of cardiovascular disease, whatever. We know the cardiovascular effects, of estrogen.
Not
Also,
to mention
gentle,
it increases your cholesterol, correct? Like a lot
yeah.
of women end up
So,
with higher cholesterol.
right. And that's actually because estrogen is responsible for the way LDL is processed in the liver. So when we lose estrogen, become deficient, becomes chaotic, then we actually aren't able to function that well, and we will see LDL cholesterol go
Right.
up. Now,
So another
another
hit to the heart.
Yes. Well, another hit to the cardiovascular system. Yeah,
Right.
absolutely. And also then the thyroid can get messed up, right? Women that don't have any thyroid, the thyroid gets messed up. Then what else we see? So very commonly we'll see new onset ADHD, new onset depression and anxiety. That's all because of the roles that estrogen plays in the brain, right? Estrogen is the body's natural antidepressant. It increases serotonin and dopamine, okay? So that's what SSRIs do. And it's no coincidence, ladies, that the biggest group of people that SSRIs are prescribed to are midlife women. Do you think that's a coincidence? It's not a damn coincidence. All of a sudden, 35, 45, and 55-year-old women don't get depression out of nowhere. It's called estrogen deficiency. Okay.
Right. You're
So
all of a sudden depressed and ADHD for the first time in your life.
ever. And
No.
then to be honest, if you already are neurodivergent, so you do have ADHD, autism, all anxiety, depression, now it's worse. Because think about this. You came as a neurodivergent woman myself, right? My ADHD. My brain already neurochemically is at a different level, right? I already have lower serotonin, dopamine. I already have differences in my glutamate. That's why I am neurodivergent. So now I come into perimenopause and shoot, crap is out of whack, right? So neurodivergent women are very perimenopausal and different. But then with a lot of women who never had these problems in their life will come into perimenopause and menopause and all of a sudden have them. This isn't like chaos, like everyone wants us to think it is. It is literally, it is neurochemistry. It is your brain transitioning, right? I can explain to you why this is happening and we can fix it. So there is psychological factors of why you should take estrogen and progesterone and testosterone, all of the things. Then gentle urinary syndrome of menopause. It is FDA approved for that. And so gentle urinary syndrome of menopause is no joke, my friends. Okay.
Yes,
We're talking
explain to the lay people what that is.
yeah, so it's where we get vaginal dryness, we get painful sex, we get UTIs, and it's not just about sex, but I will say this. We also live in, a society where we're shamed for sex, and it's like, oh, I'm old, I don't want to have sex. Yes, you should be having sex all the time. You're in your midlife, you're in the best
I'm
age.
gonna be
You're growing up.
banging when I'm 80. Let's be
Yeah, I mean,
so
I
for
got
real.
I got patients, doing it 3 times a day, and now their husbands are patients because, we fix things. I'm like, I'm gonna get known as a sex doctor around here, but that's great because we need that, right? That is part of our health. But also even if you aren't having sex, which I would argue whether you have a partner or not, you should be. There's plenty of things out there, okay? But from a health perspective, from a health span perspective, this is very important. And by vaginal estrogen, that's why I said everybody at 35 should just start vaginal estrogen. It's local. It doesn't matter, besides having some weird, very, very rare uterine sarcoma, there is actually no contraindications to vaginal estrogen. But I'm going to show you a picture actually, if you allow me. So 1 second.
Yes, go get your picture. Ladies, while she's grabbing that, this is how I, real lay people, explained the genital urinary stuff. This is what I put in my post. I was like, listen, if y'all want to keep your fun box fun and not just have it be a keepsake of good times past, then you should be paying attention to how your vagina is aging, okay?
Yeah. Do you know
You
that
do
your
skincare.
yeah,
Your vagina
it's
needs
exactly.
care,
Oh, and
girl.
by the way, speaking of that, when I put women on vaginal hormones, I allow them to use it on their face also.
What?
So it's a double whammy. Yeah, if you're not using
Why
your
would I do
vaginal
that?
estrogen on your face every day, dime
What?
size, my friend, remember, estrogen is responsible for collagen and elastin. So you get a double whammy. You treat your vaginal health and you treat your face. Oh, yes.
With
Oh, yeah.
my vaginal
Yeah.
estrogen cream. Put that on
Dime
my
size,
face?
dime size every day. Boom, done. Yep, your
My
vagina will
skincare
thank
and
you, and
vagina care
so
routine just keeps growing
yeah,
by the
your vagina will
day.
thank you, and so will your skin. Okay, so
Oh,
this is a picture. Can you see it? Okay.
yeah.
And you'll see one side. Look how beautiful, how vascular the vaginal tissue is. Look how thick it is. Oh, here's what it looks like when you have genital urinary syndrome of menopause.
Okay, and let's break down why they care about that. Because when that tissue atrophies, when that tissue starts to it gets very fragile.
Yes.
It feels like if you don't want to have sex because it feels like a bunch of razor blades poking you in
Yeah.
your vagina, that's not a good time.
No, and also what that does though from a health perspective is it increases your risk of urinary tract infections and all other infections. The other
What
thing
about
that
prolapse, Sarah? Does it increase your risk of prolapse?
No, it doesn't actually. And it's not a treatment for prolapse, but it would actually help you in prolapse because that's a muscle, right? Remember, everything in
Right.
the vagina, even to include, remember, the vagina shares a wall with the trigone of the bladder. And so actually, vaginal estrogen can help people with incontinence because it soaks up, it shares that vaginal wall, and that trigone of the bladder is also very responsive to hormones. So
Yeah,
that
so
will
that's why I
tighten
was
up.
thinking like if it's keeping the collagen and the tissues and everything healthier and younger, wouldn't that help you not prolapse? But no, there's
Yeah,
no.
I thought you said would it make the prolapse worse?
No,
So
no,
no,
no, no, no. Would
it
it
would
help
help.
prevent
Yeah,
prolapse?
it will. Yes, it will help tighten up all of that tissue, right?
Because I'm
Around
my
there.
worst fear from being an ER nurse. Oh, actually, I wasn't even a nurse yet. I
Mine's
was a
breastfeeding.
clerk, and I walked in and they were shoving a uterus back up in someone, and I was just in there to get their insurance information, and I was like, "What the hell just happened? What was that?" And they were like, "Her
Like,
uterus," and I was like, "That shit falls out." And constantly, every time I go to the doctor, I'm like, check and make sure that my vagina's gonna stay inside. I'm terrified of a
I would
prolapse.
like to keep my uterus inside,
I want
please.
my all my parts to stay where they're supposed to be.
Yeah, I do not want that. So this is a super easy thing, right? You do it once a week, it's local. But boom, I actually have 20-year-olds on vaginal estrogen because actually postpartum, giving birth and breastfeeding is very estrogen depleting, right? Having being pregnant is very estrogen rich. It's the highest estrogen you'll ever have in your entire life. Then when you breastfeed, you lose all your estrogen. So now we have these women who are just had babies. You know what it's like to have a newborn if you're a mom out there. And then now they have vaginal dryness and painful sex and they just delivered. So their life is really screwed. So we'll put them on vaginal estrogen while they're breastfeeding, give them, revive the vaginal tissue back up and give them their life back. The other thing is we call the vaginal estrogen female Viagra. And it's really true. It's because, the vaginal tissue needs hormones, right? Just like the penis does, so does the vagina. There's no difference. And so that it's like literally costs $12 for a tube of vaginal
And
estrogen.
in what way is it like female Viagra? Is it increasing sensitivity?
Yeah,
Is it
so we see it increasing sensitivity. We actually see it increasing drive a little bit sometimes. And I see that more in women who have a lot of deficit and it's been really dry and painful. And as that tissue revives again, they'll start to be like, I kind of feel some like throbbing and like the tissue is like vivacious. Also, hear a lot of like, I can actually orgasm faster, better because a lot of women will come and say, not only is it dryness, but like I can't have an orgasm, or it's so hard now. Like I have to do so many more things. This is an interesting stat that's actually completely normal, but only 10% of women can actually have an orgasm from internal stimulation. That's normal. Okay.
right,
Most women, 90% of women has to be clitoral stimulation. So if we can't, and that's again, that's normal. There's
right.
nothing wrong with you. But if we can increase, right, that and increase the vaginal sensitivity, I mean, I even had some, and everybody responds differently. Some people, you put them on vaginal estrogen and things happen right away. Some it takes 6 to 8 weeks. It really just depends on what's going on in there. The other interesting thing is that your labia, without vaginal hormones, your labia will go away. There's
Mhm.
urologists seeing women in their 70s and 80s and thought that that was normal because they weren't taught that that's hormone depletion.
Yeah, we
Literally,
see that all the
you're,
time in our elderly population.
it's because they have no estrogen.
But why do we care if we have labia?
Well, that's your first outer protectant, right?
Okay.
So
I was
remember,
like, make me care about my labia,
all of those
Sarah.
things are protecting. I mean, that why do women die from UTIs more than men, right? Our urethra is
Mhm.
short, right? The man's urethra has to go up through the penis. So anytime you're wiping, anytime you're this, and if we got ladies sitting in diapers, you want all of those protections to protect against bacteria. So that's one of the reasons. The other thing is all of that pelvic floor keeps everything cinched up there. So,
So again,
although
things not coming out.
right. Well, you don't want your uterus out. Although your labia don't play a direct role in your uterus, but anyway, the pelvic floor all being what it is, you want it all to be intact for the utmost protection as possible.
All right. So topically, we're talking about maybe easier to orgasm because for women, the clitoris is the main player there. And if
Yep.
that's decreasing sensitivity,
Hmm.
it's going to be harder.
Yep.
So you want to keep that thing.
Yeah.
firing on all cylinders.
Yes, we do.
Less UTIs, less vaginal atrophy, less pain during sex.
Yes.
Apparently, you can put the cream on your face to look youthful. You're blowing
Hello.
my mind. Uh, Systemic estrogen, we're talking about protecting our heart, our brain,
Mhm.
our
And
bones.
systemic estrogen will give us a little bit of treatment for genital urinary syndrome of menopause. So we do see that if you give systemic estrogen, some of those symptoms get better without local. But I always put everyone on it, so it doesn't even matter.
Okay.
It's like, why wouldn't you take, there's no reason not to take vaginal estrogen. But yeah, osteoporosis, right? It is FDA, estrogen is FDA approved for the prevention of osteoporosis. Um, and again, why would you, if you get an osteoporotic fracture, okay, your chances of dying within 12 months of that are 30%. What the F? Okay? So this is not a joke, right? And so here, let me say this. And we deal with this a lot in the breast cancer world of women who have actually had breast cancer. And that's very, very, very nuanced. But let me tell you, there are a lot of women who have had breast cancer themselves who take hormone therapy. And I'm not getting into that today. But again, that's a very nuanced conversation with that particular woman, what their treatment was, what their whatever. But I'll use this as a great example of talking about risk. So say that I had breast cancer, and I'm knocking on wood that I don't, and my overall risk after looking at everything was 9% chance of a recurrence. Okay. I'm just throwing a number out there. So when I'm looking at, well, should I take hormone therapy or not? These are the things that I'm looking at from a woman perspective. Okay, I have a 9% risk of potentially getting another breast cancer. There's nothing I can do about that. I've done all my treatment, I've taken all my things, like that's what my risk is. Okay. But my risk of not taking hormone therapy, right? I have a 60% chance of getting cardiovascular disease. I have a 40% chance of getting osteoporosis. And if I get osteoporosis and I fall, I have a 30% chance of dying within 12 months of that fall. I have a 35% chance of getting dementia, right? And I have all these risk factors for getting, for then there all this joint pain and all this other
Right.
stuff.
And the
My life,
UTIs
yeah,
and
UTIs and like when you have frozen shoulder and plantar fasciitis and all of these things that estrogen deficiency is. I got women who can't even get out of damn bed. I got women quitting their damn jobs who are like coaches, executive coaches to CEOs because their brain can't function. Okay, so we talk about lifestyle too, right? And your quality of life. Again, health span, not lifespan. So as a woman, you make that decision. What risk are you willing to take? I mean, I don't know if you've ever watched an ad for any medication whatsoever, but I'm like, why do these companies even put these ads? Because it's like I would never take the damn thing. Like
when
risk
once
of
you hear all
dying,
the
liver
risks,
failure, shit your pants, like all this stuff. It's like, why are you even advertising this? Like, nobody wants that. There is risk, ladies, there is risk of waking up and, getting in your damn car today. There's risk in every
huge.
single thing we do. But the bottom line is you pick the risk for you, right? You understand and educate yourself on what the benefits of estrogen are. So I want to talk a little bit about the other two really quick because they're extremely important players in the game. So
Yeah, I have
estrogen,
I have some bones to pick about progesterone, so I really want you to talk about.
okay. So estrogen, she is the queen, right? We said 400, responsible for 400 functions in the female body. Progesterone, she is our antidepressant, all that. Then, we have progesterone. So progesterone is our natural like anti-anxiety. It increases GABA. I like to call her our Netflix and chill kind of thing. Progesterone, we use micronized oral progesterone, bioidentical. I also want to say something quickly about that. That is a marketing term. What really that means is that you're not going and getting a freaking pellet, right? You're getting the actual hormone structure of what you have, right? So estradiol, E2, is what you have in abundance. You have other estrogens in the female body. But E2 is the abundant. You're getting that back, right? You're not getting a bias that has E3 and E1, you're getting the chemical structure is similar to what's in your body. You're not getting conjugated equine estrogen, right? And some women need to take that, okay? That's okay. But you're getting estradiol, right? That's bioidentical, micronized oral progesterone, not a progestin, right? That's bioidentical.
And these are the standard, this is people who are prescribing it, this is what they're prescribing now.
Yeah, I mean, people do prescribe compounded stuff and that. Again, remember, unfortunately, anywhere there's a knownness to try to make money, you're gonna have those jokers that are trying to do that. That's why I don't like pellet factories and I don't like all of that. Some, women love that. I don't like them because I don't believe in replacing women's or men's hormones not physiologically, right? To me, we replace things back the way the body gave you. Why the hell would I stick testosterone pellets in you? Your testosterone is 4. Now I just increased it to 400. As a woman, you have no business having a testosterone of 400. You don't need it, right? And now you have clitoral
Hello,
megaly, voice
mustache
change.
and Adam's
Yeah.
apple.
And a clitoral megaly, right? Because the clitoris is like a penis. And that's, guess what? If you get voice changes or clitoral megaly, that's not
Doesn't go
reversible.
away.
Now, so you're going to walk around with a penis and a low voice. And there's no reason to do that. We don't need that much, right? We need a little bit. And you want it physiologically. You want to have it given back to you the way your body gives it back to you.
Not to interrupt you, but this is an important point that I think gets missed in this conversation is when we're thinking about taking a drug, taking a hormone, we think like it's this huge mega dose. What Dr. Sarah is saying is we're not going above and be like if you go get estrogen, you're not going above and beyond what you would have had for estrogen in a younger state. You're replacing what is slowly decreasing. So you start low, you go up, you're just replacing things back to baseline. You're not going well above.
Well, you
Now,
don't want to be. Yeah.
right. I mean, and everybody gets all freaked out about it, but it's like, but aren't birth control pills estrogen and
Yeah,
progesterone,
they're
depending
synthetic.
on the
No, they're
pill,
not. They
and
are
they're a huge
synthetic
dose.
estrogen and synthetic progestins, and they're in huge doses. And then remember, I want to
That's
make clear.
above the
Oh,
physiological
yeah, that's why.
level.
That's why. So there's no such thing besides taking birth control pills of hormone balancing, right? Because balancing means zero, deadline. And that's what birth control pills do. And that's why I don't agree with young women having birth control pills. Oh, by the way, we don't want to give HRT, but we give freaking 15-year-olds birth control pills.
Well, that's kind of my point is like, we're
What
all,
the frick is really going on? Make
I'm
this make
afraid as a
sense.
menopausal 50-year-old woman to take something that I took as a 15-year-old in a way higher
And
dose
synthetic. And
and
synthetic.
synthetic.
Yeah,
And by the way,
especially
that's why they,
methadone.
so we're all worried about blood clots. That's why they tell you when you're on birth control not to smoke. But I was over here
Well,
popping birth control like candy and smoking
yeah.
packs of Marlboro Reds.
Exactly. Oh, and by the way, that also like destroys your libido and testosterone. And also, these girls are we're also looking at links to why that's why they're also on antidepressants, right?
Right.
So
And
come
I'm
on, you
not
don't want.
saying don't take your birth control pills, ladies, but I'm trying to put things in context of like, we already took estrogen.
Yeah. And I want to make a distinction too. There's in menopause and perimenopause because the estrogen how we use estrogen in those two situations is very different. So when you're menopausal, right, average age in the US is 51 and a half. When you're menopausal, really you're only menopausal for one day. Menopause only is one day. It's the day your ovary shits the bed. Okay. The next day you're postmenopausal. Okay. Then when that happens, it's actually pretty easy, right? I just find the dose that works for you, right? We titrate it up, da, da, da. You don't make it anymore. So that's fine. In perimenopause, on the other hand, it's all way more complicated because the estrogen, although deficient, the most of it is actually erratic. What we don't like as women is one day we're 150, 3 days later we're 20, and we don't like that delta in between. So perimenopausal estrogen replacement is very complex. And what we do 1 month, we're really just augmenting. And what I'm trying to do is basically augment so that delta isn't so high. Some women in perimenopause are on estrogen every day. Some women are only on it in their luteal phase. Some women take a low dose every day, and in their luteal phase, we double up. It is such precision guided medicine. And that brings up another point. If you are working with a provider or a physician that tells you that you're lucky enough that they actually will give you hormones, but then they tell you that's the only way, they're one way. That's bullshit. It's not. It's just they don't understand and they don't understand the physiology of it and how nuanced it can be. And I always tell my clients this. I get tons of clients who are on hormone therapy and hate it or like, I did it and it sucked. It's like, yeah, because the person that was helping you didn't know what the frick they were doing. But we can find a way for it to work. right? And I mean, I got women that cut patches in half. Oh my God. I mean, you name it, we're doing it, right? Because we know the benefits of it. So it's very different perimenopausally to menopausally, right? And we're using, let's just tell you this, we're using 0.25, right? 0.25 milligrams is what I usually start, unless you're menopausal or surgical menopause. Surgical menopause is a different issue. We start higher. We know that if someone has their ovaries taken out, we need to replace right away. They do better. We know this. I don't mess around with them, right? They're getting big gun doses because one day they
It
had
was
it.
abrupt.
Yes. And that's the thing. They're not perimenopausal, right? So they do worse than a normal menopausal transition because your body has somewhat been estrogen deficient over time. If you're a 30-year-old woman and you're getting a full hysterectomy with a bilateral salpingo oophorectomy, I got to replace you. I got to give you one and a half, two immediately, right? Because
Because
you
for
haven't
frame
had
of reference, you guys, you can be in perimenopause for what, 10 years?
10 to
Where,
15. Yeah.
okay, so for 15 years, you could have these fluctuations happening, and your mind and your body are okay. I don't love this, but then this woman who has surgery, it's overnight. So
Yeah.
there's the difference.
Yeah. And if we treat people in menopause, if we treat women in menopause, in perimenopause, you actually have a better menopausal transition because we're kind of like, helping you along. And it's actually one of my favorite things to do because it is so complex, right? And I love that about it, right? Like, okay, where are you in your cycle? What happened? Okay. And then my mind is like, oh, this is this. Here's this hormone. Here's this. Okay, this is what we're going to do, ladies. We're going to do this and we're going to do this. And
It's
here's
like a
why.
giant hormone puzzle.
Yeah, it's really fun actually for me. I mean, because I'm a wackadoodle and all that. But it is complicated, but it's not too complicated, right? And like we can figure this out. And that's the point of it. So, and again, the point is that you educate yourself to understand that there is benefits to hormone therapy, right? There is risks to hormone therapy, and you need to ask about them and you need to talk about them, right? And so, what was your question about progesterone?
I was just gonna say, so we got sidetracked, like me, you and I both tend to do. Progesterone.
I
This is your
told you already
Netflix
I was
chill,
ADHD.
calm your brain.
Mhm.
Okay, so I'll just tell you my beef with it, and you can tell me if I'm wrong because I'm not a doctor and I don't play one on TV either. But I've seen a lot of women who get put on estrogen alone after a hysterectomy. Rationale being, if you're on estrogen and you have a uterus, you have to take progesterone so that the uterine lining doesn't grow and blah 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 blah, all the things. But if you don't have a uterus, then you just don't need it. And then these women all hate their HRT. And I'm like, well, because progesterone does more in your body than just not grow the uterine lining, it
Correct.
affects your brain. So,
Yeah.
am I off base here?
Yeah. You're completely right. And anybody that tells a woman that has a hysterectomy that they can't be on progesterone is a raging idiot.
That's still
And I
happening
will tell them that.
in
Of
a
course it is.
large
Of course.
quantity.
Yeah, yeah. And that was actually part of the thing I bitched that doctor out yesterday about because she said the same thing. So here's the other part. A lot of my perimenopausal women, I'll ask them to go get an IUD if they still need birth control. Because remember, you can get pregnant in perimenopause. And actually, if I'm optimizing your hormones, you're gonna ovulate and you might get pregnant. And if you're 45, that may be what you want, but it may not be, right?
And
So a lot
sometimes the
of
ovaries give one last hoorah and they're
oh
like, here's
yeah,
two
and
eggs,
now you
bitches,
have a
let's
baby.
go.
Now you have a baby. So, so a lot of women will get progesterone secreting IUDs, Mirena, Kyleta, all of those things. And those are actually really great because they serve two functions. One, they serve the contraception function, and two, they serve the uterine protection. However, they're not systemic, right? So I will still put, if needed, my perimenopausal women who are on IUDs on oral micronized progesterone, right? Because we're doing it for different reasons. We're doing it for sleep, we're doing it for GABA, we're doing it to calm the nervous system, get them some parasympathetic relief. And then the same thing with the women without uterus. Yeah, you don't need it. Okay, great. But that doesn't mean you can't have it. Like, are you kidding me? You went your whole life with it, right? And there's other functions that we know progesterone plays a role in from a metabolomic side piece too. So yes, any woman can have freaking progesterone. Now, what's interesting about progesterone is three-fourths of women love it, godsend, everything. A fourth of women hate it. Okay. And these are my what I call progesterone insensitive, intolerant women. They hate it. They're like, oh my God, I'm going to kill someone. Why the frick did you put me on that? Da 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 da. Now, what I will say to that is that typically I change it to the form of a pessary or a rectal suppository, and they do fine. Okay. So again, it is not one size fits all, right? It's not just take this one pill. And I see that the most in my practice because I get a lot of complicated women. So I see a lot of women who their providers say no to them. And then I see a lot of women who have tried it or they're like, well, that's it. That's the dose. I don't know. That's the lowest we have. That's all we can do. It's like, what?
Oh,
No.
because standard people are getting, here's your patch, here's your progesterone pill, this is your dose, and I'll see you in 1 year.
Yeah. Oh yeah.
And it's just, they have
Here's
a
your
standard
prescription for
dose.
12 months. Bye bye. Bye bye now. And that's it's not like it's not it shouldn't be like that, right? It should be very nuanced and that's why it's important that you work with someone who understands that, right? And understands those little manipulations. But even more important than that, and what I tell my women and what I try to teach my clients is I try to teach you how to understand what your body's asking for, right? And so to me, that is the most valuable lesson. So as we start this journey, or even when we talk about it, like, what are your concerns? Okay, let's talk about this. Let's talk about your risk factors. Okay, you've had factor five Leiden. Okay, by the way, transdermal estrogen does not increase your clotting risk at all. It is what it is, right? I'm not going to change your clotting risk. You have factor five, so you're 4% more likely to get a blood clot than someone who doesn't, but it's not going to make you have a blood clot anymore. It's not going to increase your risk transdermally. Oral, yes, can go through the cytochrome P450 system where clotting factors are made in the liver. So all of those conversations are nuanced, right? They're all nuanced. But then the really important job that I feel like I have is to teach you how to understand what your body is saying, right? And so it's like, oh my God, I was freaking out and crying and this and that. And I'm like, well, where were you in your cycle? Right. I was like, it was right. I just ovulated. Da, 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 da. I'm like, you have too much estrogen, right? That right there is telling you have too much estrogen, right? When you feel like that, stop your estrogen for 2 days and then go back, right? It's so nuanced and so great. But the power in that and what satisfies me the most is when I follow up with my ladies and then they're like, oh yeah, listen, on this day this happened. So I went down on my dose for 2 days and then I was going to be luteal and I know that's when I have the least amount of estrogen. So I increased it for 2 days and then I started my period. So I stopped it because I have more estrogen. And I'm like sitting there like, ah, ma, ma.
Chef's
Yes.
kiss. She gets
Yes.
it.
Like, yes, because that's what we as women deserve, right? We deserve to be educated about our bodies and what's happening. And here's the other thing that I think is so, so, so powerful and so important, which is when we understand and we understand what's happening to us and we on a baseline level, right? I know not everyone is a nurse, a doctor. You don't have to be. But when you understand what's happening to your body, so you start to feel panicky and ragey. And you can say to yourself, Dr. Sarah or Nikki, they told me this is, lack of progesterone. I'm taking my progesterone tonight, right? When we can make those connections, things don't actually seem as chaotic to us, right? Because our brain is like, I know what this is. It's okay, right? It's not some crazy weird foreign thing. It's okay. I know what it is, so I can deal with it. And here's the tools that I have to deal with it. There's studies that show in certain Asian cultures, in tribal cultures, especially in Japanese, where elderly women are actually very, very much respected, right? Like menopause in those cultures is very much like a rite of passage, like, congratulations, you no longer have to procreate, right? And there's menopausal symptoms, although they have them, right? Menopause doesn't change, but they perceive them differently. How crazy is that? That tells you how powerful the brain is and how powerful understanding what is happening to you. They still have hot flashes, but they perceive them very differently. And unfortunately, as women in the United States, we live in a culture and in a society where we're just told we're crazy from day one. Right? Why didn't we ever do research on women? In the 1950s, the FDA said women are too hormonally complex. Do you know who said that? A 60-year-old white man. Do you want to know why? Because he's a pussy, right? Like if that was me, I would have been like, oh my God, give me the most hormonally complex person because if I can fix that person, and like from a scientific
But
standpoint,
no, 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 Sarah, because if you include them in your study, that's too much noise. You might not see the signal. You might not get your drug passed because you don't understand.
yeah,
Yeah.
yeah. But I mean, come on. Like, well, first off, to me, that's coward, that you're being a coward and a pussy. Like, so you're gonna go with an easy route, not the hard, like as a doctor, I would be like, give me the hardest thing, right? I want the hardest case. Because when I can solve that and I can break that and I can get the answers to that, well, voila, I've won. Now what have we done? We've done nothing. We actually, there's just a study that came out on beta blockers. I don't know if you've seen this, but beta blockers actually kill women.
No,
Okay?
I did not see
Because
this.
they were not studied on women. Women actually have, in MIs, have poorer outcomes on beta blocker therapy. It was just released by the Cardiac Society. So, yes, yes.
My little note. You know how I love to thumb through research articles,
But why? Because women, it wasn't studied on women. These were all studied on men and white men for the most part, right? And not all, but like
which
for
we
the
know
most part,
cardiovascular stuff is very different between
exact
men and
ethnicity
women
and
and different
ethnicities. Yeah,
cultures,
yeah.
ethnicities. Yeah.
So women do poorly on beta blockers. Okay, we're killing women for the sake of what? We don't want complexity, right? And that is also true from a hormone therapy perspective. I always say we're killing women in the voice of saying we're protecting them. And here's another reality. We've done a really good job of bringing breast cancer to the forefront, and I do not want to belittle that at all. Breast cancer is a serious thing. But right now in the United States, if you are diagnosed with breast cancer, your survivability rate is 94%. Okay? So we've done a good job of scaring women about breast cancer, and it deserves that attention, right? But women, for the most part, are not dying from breast cancer the way they're dying from cardiovascular disease. And you can't sacrifice one for the other. Women are over here keeling over and dying every day from cardiovascular disease, not breast cancer. And I don't want anyone to have breast cancer. And I'm not belittling breast cancer. That's not what I'm saying.
No,
What I'm saying is that we've created
but
a
we can't just
dichotomy.
focus on one
Yes,
thing.
we've created a dichotomy in the name of doing good for women, right? But we're
Mhm.
not, right? We're not. We're bypassing this whole other piece. And then not even to get into the fact that women we do cardiovascular disease differently, right? We don't have a I'm having MI. We have like,
We
oh,
have our little bit of heartburn and
my ear
like,
turn, my nose hairs. I have a little, nausea. And then we'd forget about it because we're busy and we're this and we're that. And then we
Mhm.
die in our sleep, right? Or then we do come in with the big MI and or we go in and we're freaking dismissed. Let's try that one out for size because that happens, right?
Mhm.
So we can't sacrifice one for the other. We have to know it all, right?
And that's the point of us having this conversation today, you guys. I know we both sound very pro HRT, and that's because there are many benefits. But the point is to just have conversation about this, make you
Yeah.
aware that this whole other piece of your health exists. And it might be right for you to start on something, it might not. But we shouldn't be afraid to have these conversations. We shouldn't be afraid of all of our treatment options. We need to be loud about this so we do get better studies. And you're like, this is the best time of your life, in my opinion. And we're making it as though we have no control over menopause. We're just crazy and our bodies are out of control, and I'm just gonna be overweight now and never sleep again. No,
Yeah.
no, you have control of this. That's why Dr. Sarah is saying when you understand the symptoms that your body has and you know what to do about it, it's so empowering. It's not happening to you, it's happening with you. It's a normal phase of life. And we're so much better at this age. Don't let this transition feel like you're just losing control. Like, no, girls, we're just gonna own it. Like this is our time. It's an amazing phase of life, but you need people in your corner to support you who have really good practices to help you
Yeah.
make really good decisions.
You need partners, right? And you're right. And this is I don't care if you take HRT or not. I really don't. I mean, I want all women to if it's right for them, obviously, because I want women to live long and healthy life. But I don't really care that if you do or don't. What I care about is that you make the decision to do or don't based on evidence. But also here's the thing. we just talked about a huge dichotomy from a women's health perspective on who we study, and what we do. There is a lot of things that are never going to get a retrospective clinical trial, right? And so we also have to be honest, right? And we also have to say, hey, this is what we know and we have data for. This is what we don't know and we don't have data for. But this is what understanding female physiology, why this makes sense. And so the point is having the conversations. The point is not being told no by somebody that doesn't know you and your body. The point is understanding who you are, what your risk factors are. And then here's the other point. What do you want out of life? Right? Like, what is
What
your
matters
life?
to you?
Yeah, because what matters to you is different than what matters to me, which is different than what matters to Nikki and all of the friends that you're standing there with. And that's what happens in this world of social media. Unfortunately, it's great, right, in some regards, but then it's like, oh, everybody should do this or that or this or that. And nobody stops to say, what, and we don't even stop to say, what do I want out of life? What does this next transition in my life look like? How do I want it to look? How do I want to feel? What do I want to do? So I would challenge every single woman watching this to stop for 5 minutes and just really give that some thought, right? Take a deep breath and say to yourself, what do I want for myself? What do I envision this next chapter of my life looking like? And how do I get that?
And that's how you make the best choices for your medications, for your hormones, for what supplements you take, for what your exercise routine looks like, for how you're going to eat, what boundaries you're going to have in your relationships. It all needs to stem from what do you want in this season of life? You get to write this shit. Your kids are grown. You're more resourced now. You're not a broke 20-year-old. You're an older established woman who's raised her children, and you get to decide what the this season of your life looks like. How do all these things help or hinder? What choices do you want to make? Like when my clients are like, or anybody, we're going through stuff. Well, what do you want this supplement for? I don't know. What? No.
Yeah.
Your HRT, I want you to know why you're taking it if you're
Sure.
taking it.
Yeah.
Your supplements, I want you to know why you're on them if
Yeah.
you're on them.
You know,
However, you're eating, why are you eating that way?
yeah.
Know
And
why
that's
you're doing the things.
you're actually talking about actually healthy people who are health conscious. Like there's still a majority of the United States that will come into a hospital and say, "Why do you take, these medications?"
My
Well, I don't
doctor told me to.
what? Like these are prescription drugs, right? Or like, "Hey, who did your open heart surgery?" Well, I don't know their name. I'm like, "Okay, so you let somebody cut into your chest, operate on your heart and you don't know their damn name?" Okay, guys, ladies, gentlemen, I don't care. Maybe there's guys listening to this too. This is
Right.
an overall like please understand what you're doing and why you're doing it. Stop letting the system tell you to do stuff and take control about why you're doing it, right? If your doctor says, I want you to go on a statin, and let me tell you this, I have my own feelings about statins. However, there is a time and place for everything in medicine, to be really honest. There is not, you can't say all statins are bad. Nobody should there anybody that says something like that doesn't is
There's
not
your red
educated.
flag.
Yeah, that's a red flag. Anybody that's like, you should never do this. It's a red flag because there is somebody somewhere that should do that, right? There is an indication, and it's very much more nuanced than that, but there is an indication for doing that. But the point is don't leave the office and they said, oh, your LDL's up, here's a statin. The conversation should be more than that. Well, why is my LDL up? Like, what else can I do? Can I, is there something I can, whatever you want, right? You may want to take the statin. I've had clients come in and be like, give me the damn blood pressure pill because I'm not gonna do what you tell me. I'm like, okay, well, you're gonna die, but that's okay. That's your prerogative. You get to live life the way you want to, but just do it educated, right?
Right.
We unfortunately in medicine 2.0, there was a lot of like, I'm the doctor, I'm the boss, right? You're doing this because I said so. And that's horrible. That's horrible medicine. That's to me, I hate that. I do not like that at all. It really should be like, we're partners with you, right? Like I'm your consultant, right? Like I went to school for a bazillion years. Like, trust me, there is no one more up to date on women's health, longevity, all of the things. And I'm going to be completely honest with you. If I don't know, I'm going to find out, with you. But I'm your partner, right? I am your consultant. I have the knowledge. I went to school, but I still have to give you health and longevity through what you vision that to be. And so
Yes.
that's what you have to have. You have to partner with someone who's going to listen to you. And you know what? Frankly, they may say, you know what? I actually don't know about that. Or like, let me go read some studies. Let's come back in a week or 2 weeks and let me do that. And that's okay. That's great. We're doctors. We're human.
That's
We didn't know
wonderful.
everything. Yeah.
Yes.
And we're busy, right? So like the somebody that is willing to take that extra step and be like, listen, I'm actually not up to date on this. Give me a couple weeks. I want to get up to date on this because I'm with you. I think that there's value in at least me understanding this better for you. And doing that is powerful. And if they
Mhm.
aren't and they're not willing to, there's so many doctors. Okay, goodbye. See another one. Get rid of them because they're not going to be what you need for health and longevity. And that's not even just in the hormone realm. That's just in general, right? If they're not willing to have a conversation with you about the whys, the hows, the other things, then goodbye. It's time to go.
Mhm.
And maybe then they'll all go
Agreed.
out of business and get fired. And then, that'll be great.
Okay, so I feel like this is a good point to go. Where can our listeners follow you, learn from you, with you if should they so choose?
Yeah. So I have a lot of social media. I am on Instagram at lesh.life.style. I have a YouTube, Dr. Sarah, leshlifestyle.com. I love, or .com, geez, oh, Pete. Perimenopause brain here on YouTube. I love my YouTube because it's just really about education, right? And it's very short. I don't do anything you I think, I mean, I have some hour stuff on there, but a lot of things are 4 to 10 minutes, just getting the reality. What the hell is estrogen? What's progesterone? How do I, should I use a red light? Should I do zone tutoring? What the hell is that? Like, should I do, all of these things, right? Just very educational. And then, of course, if you live in Michigan, Florida, Texas, or New York, you can always work with us. I do telemed in those states. And then one really powerful thing is joining our Women's Next Level Collective. So this is really an amazing place where I always laugh. I need to. I think we talked about this. We need jingles. Like I need jingles to come back. Like back in the day, there was such good jingles, But I always vision it as like Cheers, like go where everybody knows your name and they're always glad you came, right? And obviously, I can't copyright Cheers, but that's exactly the my vision for the Women's Health Collective. Inside of it, I do a monthly intensive, an hour every month on a different topic. Sometimes it's hormones, a lot of longevity, peptides, whatever the heck it is. And then we have a longevity lab, which is really cool. You go in and they're really short. You get one every month, and they're really meant to help you make small habitual changes and make them seem easy, right? So it's like this month you're going in and you're doing a change on circadian rhythm, right? And you're learning about that. And you have a whole month to implement that. And then if you look back at the end of the year, you've made 12 habitual changes. That's freaking impressive.
I
That's
love
amazing.
that.
And these are like little short blurbs. One of the other cool, powerful things is I do a newsletter every month that looks at all the latest, greatest research that's just come out. And I write it out for you, but I also voice it out for you. So then you get, my little commentary. Um, and I always link you to that and anything kind of like up and coming. We have amazing guest speakers and guest lecturers on there. Nikki's actually going to be one. So yeah, yeah. And we also have something called Chaos to Clarity, which is looking at other things, right? That are not just women's health from a health perspective, but more from an executive level perspective, where we are in our life. How do we take back energy? How do we stop making a million to-do lists? How do we be the best women we can be in our lives and manage our lives the best that we can with the realities that we have? And we have a WhatsApp chat, we have a Facebook group. So it's really just a community where we can go, you can get accurate information and you can bitch if you want, right? You can be like, this is what's happening, or I hate this, or blah, 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 blah. And there's all these other women who understand, right? And help you. It's the best club on the earth. So that is also available for everyone. It's the Next Level Women's Collective. And I really just want to thank you. I want to thank you for having me. And I want to thank you for taking the plunge of helping women just understand what they need to know, educating them, and being real, right? Because that's exactly what this is about. It's real talk. and no fluff, no nothing. And so I appreciate you and your time.
Oh, thank you so much. And I will link to all of the stuff that she just said for you guys in the show notes of the podcast episode. So if you want to follow her, if you want to jump into any of her memberships or whatever, all the links will be there. And I hope that this gave you all lots of good food for thought. We could have kept talking for probably 7 hours. Because this is a very in-depth and nuanced conversation. So there's more education to be had about this topic, but there's your overview. I hope that you're all no longer terrified of HRT. Thank you so much, Dr. Sarah, and I will chat with you soon.
Bye.